Good afternoon. I want to welcome you to the Joint Legislative Oversight Committee on Medicaid. We're happy that everybody's here today, and I want to recognize our Sergeant at Arms. Guys and ladies, if you'll raise your hands, I think it's all guys today. If you'll raise your hands, I would like to recognize you. And Rob Fuller, are you back there in the back? Matthew Lee, Chris Moore, David Leeton, Russell Salisbury, and Glenn Wall. And we have our head Sergeant at Arms over there. And we appreciate you being here and looking after all of us and making sure everything's good. So glad everybody's here, and I think everybody's getting seated and ready to go. At this time, I'm going to call on Jay Ludlam to give remarks from the Department of Health and Human Services.
Good afternoon, Chairman. Jay Ludlam, Deputy Secretary, North Carolina Medicaid. Privileged to be here today. We have a lot to talk about today. Some really exciting news coming out of some of our transformation projects and programs. In addition to updates on NC HealthWorks and our Pharmacy Benefit Manager program. So a lot to cover in a very, in a very short period of time. It'll feel short. Last, I will give a brief update. Last JLOC about 3 weeks ago mentioned the Change Health cyber attack and its impact on technical systems for providers. I just want to share with the committee, we are not seeing a lot of hardship requests. We are seeing some, but you may have heard in other states, a lot of providers were hit and hurt by this cyber attack. It's affecting their cash flow. It's been a little over a month. It's been about 6 weeks now. And so what I want to say is to those providers that have not reached out for hardship requests but are struggling and trying to understand what to do next, we encourage them to reach out to the department. We stand ready. Our managed care partners also stand ready to support them. Anecdotally, we've heard that North Carolina providers don't generally use this vendor, so we may have dodged a bullet, but regardless, I just wanted to reiterate the message to providers that there are resources available to them through the department and our managed care partners. But that's it for my opening remarks, and so I'll turn it back to you, Chair.
Thank you. Appreciate that. And at this time, we'll recognize Adam Levinson, the Chief Financial Officer, to talk about Medicaid enrollment and financial update.
Thank you, Mr. Chair. Members of the committee, it's a pleasure to be here. I have a very brief update for you. I think this is unfortunately becoming common and hopefully isn't too boring, but sometimes in finance, boring is good.
Good numbers are not boring.
So you've asked us to remark on the same agenda, and I have the same slide set for you. The only two that have changed are the ones that look at enrollment, so they've been updated for the actuals. As you can see here, we are on the same trajectory that we were on last month. Last month, I did talk about a new trajectory since the prior meeting, and that's where you see it changing, inflecting to go up a little bit higher, and now it's a little flatter overall than it was for the prior months. As we talked about last time, what that means is that in aggregate, it is staying a little bit higher, but the mix, as it turns out, is changing a little bit because it is children who are being added and or staying at the higher rate to keep it higher. And so what this means for expenditures, as we talked about last time, is that while the enrollment in aggregate is staying a little bit higher, because it costs less to serve children than it does to serve adults, the added cost of the enrollment being a little bit higher is not as much as you might expect. It is a little bit, but it is not more than what we had projected and discussed last time. So staying on the same trajectory, no difference in what we expect it will add to the end of the year financial position.
Very good. All right, I'm going to open it up for questions. Were you done? Were you going to go through the last one?
I have one more, but
Okay,
but
go
it's
ahead. I thought
a
you
lot
were
of this.
winding it up. Go ahead,
Another
finish
view
up.
of, no problem, sir. Adam Levinson, DHHS. This next slide, again, just an advancement by 1 month of our expenditures, our month-end expenditures. This is through February, and here you can see that we've spent approximately 64% of the appropriations budget for services. This is the vast part of our budget. There are some small dollars for admin, but the budget for services, we've spent approximately 64%. This is 2/3 of the way through the year. So if you were straight lining it, 8 months out of 12, you might expect us to spend 67%. So you can see that we're a little bit below, a little bit behind on budget, and that's a good thing. But as we talked about, each month we're making it up a little bit in the back half of this year because the federal match is lower, or I should say it was extra high in the first half of the year because of the remaining enhanced FMAP from the public health emergency. So we are on track, as I've mentioned before, to be within that plus or minus 1% range. At this point, we don't see anything new that would lead us to think that we're going significantly outside of that range. Of course, things can change in a quarter, and we'll be working very closely with your staff and with you all to update you as we see more in April and May. Now, I will be happy to take questions.
Okay, I want to make sure that I'll ask you the first question.
All right.
So if you were to go back to the graph there, if you were to draw that line straight on out, what would it look like through the end of June?
Well, it would be something that is above the blue line. So it would be higher June 30th enrollment and therefore starting enrollment for the next fiscal year than we had projected. And we've talked about the reasons for that. So it is definitely a slower continuous coverage unwinding than we had expected in some respects. We did obviously access the flexibility to extend children for 12 months. So that is not unexpected that part of the enrollment is staying higher. But as we've discussed, we believe that will enable a higher or faster redetermination rate for adults than otherwise. So it's a trade-off, but we believe for cost purposes and other purposes, but for cost purposes, it should still be a win.
On the redetermination, I know there's been a lag. Some of the counties are pushing back. Tell me, what is that looking like? Are the counties getting back on track on doing the redeterminations? Or because, I mean, every month they push somebody back, they're pushing other people back too. So are we going to catch that up and get back on regular track with redeterminations?
Yes, sir. Adam Levinson, DHHS. I'm going to turn that over to Jay, who is, I think, more familiar with some of those details.
Chairman.
Deputy Secretary?
Yeah, thank you. Jay Ludlam, DHHS. What we saw initially was, of course, we saw during the fall, we saw an uptick in applications, and with the redeterminations not using the E14 flexibilities, we did see an increase in applications and redetermination backlog that started in sometime in the fall, maybe November or so. We are seeing positive trends for our county partners. They are working through the backlog and making good progress. In anticipation of today, we did take a look at our adult disenrollment, and what we're seeing, not adult disenrollment, the number of applications and redeterminations for adults that the counties are able to get to, and we saw a 20% increase in their processing of those adult applications and redeterminations. So again, from a budget perspective, we believe that we're plus or minus that 1%. We remain there.
Okay, so just to follow up on, so you've seen a 20% increase, but how far behind were we? I mean, were we, 1 month, 2 months, 3 months behind on doing redeterminations? Because I know they're supposed to be on a 1/12 calendar to do that. So I'm just trying to govern where we're at in the program.
Yeah, and I might need to get a little, I wasn't prepared for that exact question. I think that what we're seeing is we're generally, like many states that are compliant, we're a little bit behind the 1/12. But we, I think the expansion, the ability to put people into expansion has really helped in terms of throughput. But regarding the backlog, I would need to find out where we're at now that we've processed the entire month of March. So if I can bring that number back to the committee, I'll do that.
Thank you. All right, open up for questions. Representative Blackwell. What? Okay. All right.
Somebody get her. Let's put that on.
Senator
I'm
Heiss.
saving up.
Thank you, sir. Senator Heiss.
Thank you, Mr. Chairman. I'm really trying to get a little bit behind this. The Medicaid enrollment excluding family planning, but most family planning shifted to expansion in that. So just trying to get the sense of where it's going. And I guess the biggest question is, if enrollment was able to proceed redetermination for minors in this process, what would you expect the enrollment levels to be? Because, I mean, we pay a per member per month payment out, so their utilization doesn't change it very much. I'm just trying to get to a sense of, because one of the changing factors is we put off determination for a year, so I'm trying, how close would we be otherwise?
Adam Levinson. Go ahead.
Thanks, sir. And then if you'd like to say.
Or Deputy Secretary, either one.
Go ahead.
I almost forgot the question now after all that back and forth. I think that, you know, from a cost perspective, children in our capitation for Medicaid managed care rates is lower. It's I think it takes 2.5 kids per adult. So from a cost savings perspective, or from a cost perspective, what we're seeing here, and this is, I think, a shift in this post-pandemic world, is that we're seeing a shift where the enrollment and the budget don't track as closely as they did before. I think in the past, we would have been able to look at enrollment numbers and effectively draw almost a clear line. And now we're not able to do that. And I think that's why we remain conservative in our plus or minus 1%. As we see the data continue to, we call it mature, as we become more familiar with it, and we are more confident that that any given month is more of a trend rather than an outlier. And so we continue to monitor the data and watch the budget both.
Follow up.
So let me kind of summarize it with this question. It's 1st of April. We'll be back in about 4 weeks and starting this wonderful budget process. At what point do you expect this to kind of dial in for rebase determinations that will be necessary?
Deputy Secretary Ludlam or Adam Levinson.
Thank you, Mr. Chair. I'll take this one. Adam Levinson, DHHS. Senator Heiss, a great question. We are simultaneously monitoring this, analyzing this current year, because obviously it's, as we've talked about, there's uncertainty and it's unprecedented, and so we're wanting to understand where we are and where we're headed. At the same time, we've been working hand in hand with Office of State Budget and Management on preparing for next year's rebase. And as you know, we've talked about, of course, there was a second year in the rebase that was put forward in the biennial budget, but we know a lot more now than we did when we had to put that in. And so the rebase request that comes out in the governor's budget will be adjusted for the best information we have available, certainly now and going forward a little bit, as long as we can.
Senator Heiss.
Just to refollow up, trying to get to the when of that question you anticipate.
Mr. Chair, Adam Levinson, DHHS. I can't offer a date when the governor's budget will be released, but we are working very closely with the OSBM team to make sure that they have the best information that we have available and projections that we think are most appropriate for the enrollment and for the capitation rates for all the different programs. And so all of those things will be adjusted, and they will be different than that line that light blue line you see there, which was the second year of a 2-year plan much earlier when we didn't have as refined information as we have now.
Deputy Secretary, did you want to add? Okay, you turned your light off. So.
Well, and you shouldn't have sat us together, right? But J. Ludlam, DHHS. What I would add is we do understand the sense of urgency in locking down these numbers and making our recommendation. And we are, I think there are many of us who would like to take it all the way to June 30th so that we can be perfect and know exactly how much we need this fiscal year, as well as start the next fiscal year. But because we don't get to operate in such a world, I think what we're in the process of doing is trying to come up with the most narrow range for the forecast so that we can provide you and, of course, the Office of State Budget and Management the best information possible. So that's where we're at.
Any follow-up?
No, I'll just say that for everybody who doesn't know, we're working on a timeline that assumes much work completed by June 30th versus beginning. So
time is of the essence.
Mr. Chair, if I could add one more thing. I think I failed to mention, Adam Levinson, DHHS, I think I failed to mention that we are working very closely with the fiscal research staff, as we always do. We have a standing call every other week, and your team is working very hard to understand where we are in the current year. We're working with them. There's a lot to analyze, and so we'll continue to do that right up until you need to hit go. So we understand that time is of the essence.
Very good. Other questions? Seeing none, we'll move on to the Medicaid transformation update. Deputy Secretary Ludlam.
All right. Yes. So I think Luke is going to set it up. All right. Well, good afternoon again. I don't know if I should change it up each presentation, but I'm very excited about some of the work that we're going to share with you today. There are 2 top-line messages. I don't want to bury the lead, quote unquote. The first is that tailored plans will be going live on July 1st. They have successfully completed our readiness program, and we will talk a lot about that and the opportunity that presents the state and communities all across North Carolina. I will also share a little later on, too, after that announcement, I will be sharing some very promising initial results about the Healthy Opportunity pilots that indicate potential cost savings, as well as indications that we may have some clear clinical benefits for beneficiaries. So some really, really exciting things to announce today. I will go to a slide that many of you had to see, over the last couple of years, and this highlights. It combines actually these 2 successes in one, and this is the original vision that we set forth to implement as we transformed Medicaid. And you will hear many of these themes. I think I've read this slide enough to you all that in the past that I don't need to read it again. But there are some real components in the tailored plan work related to whole person care, as well as that whole person centered and the well-coordinated part, in addition to our Healthy Opportunity pilots and addressing the non-medical drivers of health in connection with the medical drivers. But first, let's talk about the exciting launch of tailored plans in July. So what I'll start with first is just that we have spent a lot of time working with the health plans to validate that they are ready for this launch. And there are I'm sorry. We have been, this is our readiness work is part of our effort to make sure that we have a smooth go live on July 1st. It's important for the people that participate in the program and the providers that support those individuals. We have taken a lot of time working with the plans, reviewing policies, desktop procedures. We have gone through testing, user acceptance testing, system integration testing, end-to-end testing, and we have reviewed hundreds of documents and interviewed tens of people across the organizations to make sure that they are ready to go live, that they are ready for that smooth transition. I won't read this slide verbatim, but I think, again, the key point of all of this is to be sure that the health plans are ready to do the work and that we at the department are ready to oversee the health plans to ensure that they're doing the work correctly. Last year, we presented, around this time last year, I think it was March 1st, my second hour in the job, we had presented a heat map. And it had orange and red in that heat map. I couldn't come up with something witty. The secretary is not here. He couldn't help me. But I will call this a cool map. But we're really seeing a lot of green and yellow. And for a launch of this size, I'm not surprised that we're seeing a little yellow. And in fact, from our perspective, from the department's perspective, the way we talk about readiness, knowing where our potential risks might be helps us develop strategies and contingency plans to support those areas. And so I'll highlight a couple of the areas, not because I want to talk about the things that aren't going well, but I do think it's important that the committee understand what yellow means. And so for the non-emergency transportation, there is a benefit that is offered members, and that is transportation to and from appointments, to and from the pharmacy, so that they can get services. For this population that is served by the tailored plans, they use a specialized non-emergency transportation program, and that's called NEAT. That's non-emergent ambulance transport, and that would be for individuals who might have a wheelchair or need specialized transport. And so we would like to see the health plans continue to work with local communities as well as their brokers to expand and increase access as well for that component of the program. You also see a little bit of yellow, too, on provider payment and authorizations. I think that we are in a vastly different place than where we were this time last year. What we have here are some items, some small defects that the health plans have time to continue to work on between now and when claims will be submitted in July. And we anticipate that the work that it remains is very doable and is not a reason for providers to not contract. In fact, we continue to encourage providers to contract with the tailored plans. We do not see the claim issues that might have happened this time last year. So we feel like we're in a much better place. What isn't represented in this chart, and I don't know how to articulate this in this kind of setting, but when I think about all the work that the tailored plans have done over the last year, the work around consolidation, there was one moment that for me actually indicates how much this system has changed in such a short period of time. And that is that some of the health plans were at one point struggling with a technical issue. And one of the health plans had figured out the solution to that. And they shared it with one of the other plans so that the other plan could accelerate their learning, accelerate their technology development, and close the gap. And it's that collaboration, that system approach that I think is so important for a program like the tailored plans to work appropriately and properly here in the communities of North Carolina. So I think that, again, the department feels confident that the tailored plans are ready and are ready to go live on July 1st. So this now becomes a timeline slide that we all should be paying attention to a little bit more closely than we may have 6 weeks ago. But this is, the impact and the actions that members will start to see. And we want you and the members here at the legislature to be prepared for any questions. We have stood up our help center. We are prepared for questions. And of course, the health plans are working with their call centers to be prepared for an influx of calls that may come to them. So over the next couple of weeks, you're going to start to see materials go out to members and their families, and they will begin to get more and more engaged with the tailored plans as we get closer to July 1st. I'm not going to talk about that. I won't talk broadly about this. So I will talk about this. And this slide is regarding the flexibilities that we are requiring the tailored plans to honor over the next couple of months as we transition into this program. We have talked a lot about how the needs of the population that are served here are very specialized. And we do not want people, let me back up. We want a smooth transition. And one of the ways that we believe that we can get to a smooth transition is creating flexibilities for providers as they become familiar with a new way of doing business, perhaps even with an entity that they've worked with in the past. But there are new ways of doing business. There are new rules under the Tailored Plan program, and we want our providers to get used to that as we get our feet under us in this program. Very much like electronic visit and verification, hard launch and soft launch. This is a way of doing soft launch. This is a way of paying providers and educating them that in the future you will need a prior authorization for this service. But we will pay you today. But please understand, do you know how to get to your prior authorization, get through that process? Similarly, we will be offering flexibilities for participants, for members, to be able to switch primary care providers. While our tailored plan partners have met our threshold of 90% of their members not being disrupted by this transition, we encourage our tailored plan partners to continue to contract, to continue to find primary care providers. And as they do, as they bring more providers into their networks, we want people to have the flexibility to switch and get care from those individuals that they best feel will give them that care. So we'll be offering flexibilities to providers and members. If we find that the system is not as smooth as we'd like, we may extend these flexibilities. We did that with our standard plan launch. We extended them, I think, for 60 extra days because that was the right thing to do to support members. So this is my last slide on tailored plans. I know I have a healthy opportunities piece. Chair, I'd love to talk about healthy opportunities, but I don't know how you want to split it up. Would it be easier to take questions on tailored plans first?
Let's stop and take some questions on tailored plans. Representative Co-Chair Potts.
I have a question on slide 4, on page 4. Which one should be the most concerning to us? A mild member abrasion for not getting service, or a mild provider abrasion for not getting paid? in the yellow highlights there under getting ready to go live March 22nd.
Deputy Secretary.
Yeah, thank you. Jay Ludlam, DHHS. We encourage we encourage the Taylor plans to resolve the mild abrasion, quote unquote, for both those issues. I think mild abrasion means that we will need to continue to work on contracting with the non-emergency transportation brokers, and we will expect and look for the health plans to support providers through that claim payment process. Part of how we're addressing mild abrasion is those flexibilities that I just talked about. If they're unable to resolve those issues and we continue to have abrasion, we will continue to extend those flexibilities. And so our way of managing those issues or potential issues is to develop those mitigations and contingencies that support providers or support members through these moments.
Follow up.
I'll let it go.
Okay. Other questions? Representative Baker.
Thank you, Mr. Chair, and thank you so much, Deputy Secretary, for the presentation and for the hard work. I know it's been quite a lift for DHHS and especially for our LMEs. Really appreciate all you've done to get to this point of being ready to launch the tailored plan officially. So I had a couple of questions that I'm hearing sort of from some of my providers locally as they're anticipating this. And so it's a two-part question. One is in relation to whole person care and the care management. And it's I want to address it now because, my first question was, well, what about the healthy opportunities, but I know those are only pilots. So kind of understanding what I am hearing is an anticipation that while care management will be sufficiently reimbursed once things are settled, that right now there are some new populations, it's a whole new procedure, and there's a lot of crisis mode still. So that while care management fees may be sufficient once tailored plans are off and running, in the startup, whether it's housing and paying bills and all that we do with wraparound, that perhaps care management is going to be a taller lift on that end. And then somewhat related is kind of the status of NC Care 360, kind of where that is. Are the shelters using it? Are things getting logged in? Will we really be able to track what's going on?
Deputy Secretary.
Jay Ludlam, DHHS. I think the first question is related to tailored care management and our move to tailored plans. So tailored care management was supposed to launch in connection with tailored plan back in December of 22. When we delayed, we still felt it was important for us to begin to work out any issues with the tailored care management program, but also to begin getting some cash for the investments that care management agencies had made in preparation for go live. What we have seen over the last year is continued increasing adoption of tailored care management. We saw some of the use of the program at levels the engagement levels were a little below what we expected, but we did not feel that we had because of our budget situation, we didn't feel like we had more money that we could put in the system. So our teams worked very hard to find some additional funds. And what we were able to do is take some of the money that hadn't been used yet and was not projected to be used and actually increase the rates for the rest of this fiscal year. So we have actually bumped up the rates for tailored care management through the end of this fiscal year. We believe that we are seeing just continued growth of the program. We're seeing better numbers in terms of engagement now, and we anticipate that after July 1st, that improved engagement will continue. But we don't feel like we have any additional funds right now to put into that program. So I think we believe that tailored care management will really benefit from tailored plan launch, and we think that the core benefits of tailored plans will be this care management, coordinating the physical and behavioral mental health needs of individuals.
Follow up?
So you feel that the tailored plan starting is going to assist the care management that I know has already been occurring in what fashion that as they're getting these services, the care management, because again, I guess I'm sort of looking at the wraparound parts of it most specifically.
Deputy Secretary.
Yeah, Jay Ludlam, DHHS. I apologize. I might welcome just a different conversation just to talk offline about what you're specifically concerned about so I can address it directly. Related to NC Care 360, your second question, actually, that's my next presentation. So,
Representative Cunningham.
Thank you, Mr. Chair. On page 4, line 4, the PCP panel management. According to, as you're going across it for the primary care providers, that's about 11,800 clients that would not be able to continue with their historical. So that's continuity of care. So what's going to happen in that space?
Deputy Secretary.
Yeah, Jay Ludlam, DHHS. I think that's a fantastic question, and absolutely something that we're all focused on. We established that disruption index or standard, which was to preserve 90% of the existing historic primary care relationship. For that very reason, for that you don't want to disrupt care. You want that continuity. It's critical, especially for this population, though it's harder to say even especially for, but yes, absolutely for this population, continuity of care is critical. The absolute numbers are something that the health plan should be focused on, maybe in a minute they'll talk a little bit about some of their strategies that they will use to continue to look for more providers to participate in North Carolina Medicaid, for more providers to contract with the tailored plans and with the standard plans, and do what they can to support members, maybe with a quote unquote single case agreement, or do what's necessary to support people for that continuity. Again, I'll go back to those flexibilities that we're offering. Those flexibilities are designed to not require prior authorization, so that a provider who might have doubts in the back of their mind about whether they can really work in this new system can take the time to become familiar with the new organization, the leadership, the claim filing systems, and become familiar with it, so that's a way for the tailored plans to sell their program and to get providers to take care of these members. It is absolutely a focus that we are preparing to support members with, continue to pressure the tailored plans to get more contracts in place, and where they can't, to support their members in the way that they need, so that they don't disrupt that care.
Did you have a follow-up? Okay. Senator Adcock.
Thank you, Mr. Chair, and thank you, Mr. Secretary. So my question is about the cool map that actually is a hot slide, number 4.
Yes.
So it's about claims payment systems, and it's a multi-part question, probably with some follow-up. So what kinds of claims payment systems are the LMAs using? Are they required to use the same one? Can they use different ones? So tell us a little bit about that, and then a couple of follow-ups, please.
Deputy Secretary.
Jay Ludlam, DHHS. They actually are permitted to utilize their own. They have the ability to build their own, or buy their own, or work with a standard plan partner, for example, to operate the claim system.
Follow up.
So does that mean there are 4 different ones, or do you know?
Deputy Secretary.
Jade Ludlam, DHHS. I think technically the way to think about it is there are 4 different ones, yes.
Follow up?
Thank you. Thank you, Mr. Chair. So I think about there are many striking things about this slide, and one is that the lower half is about the provider experience. And I know that the more different ways you have to do something, the harder that provider experience is. So that was the source of that question. And that brings me to the testing question. I was taken by your description of all the many things that have been tested. So I wanted to ask, how is testing of claims payment going? Give us
Secretary.
an idea about that.
Yeah, Jay Ludlam, DHHS. So claim testing, we have run 4 different test paths where we grab thousands of historic claims that have been submitted to the department, NC Tracks, and what we do is we literally run those claims through the health plan claims systems, and we look for basically we're looking for the same results that come out of Tracks that will come out of the LMEs, and so we validate that. We make sure that the payment amounts are right, the quote unquote edits have been fired, and all of the necessary detail that goes into that. So that's part of our claim testing. And as it shows here, what we see is that the claim systems are up and running and performing well.
Follow up?
Thank you, Mr. Chair. So when does it go from historical claims to real-time claims testing? So in other words, if I can restate that, so the provider submits the claim, there's a hitch, maybe there's just something modifier, something they needed to use or something like that, and they actually get paid. There's some facilitation, whether it's hand adjudication, whatever, so they actually get paid for that claim learned from that experience.
Deputy Secretary?
Yeah, Jay Ludlam, DHHS. They will when we go into production on July 1st. So they will provide the service on July 1st, and probably around the 3rd or the 5th, they will submit their claims, and then that process will kick off, and they will potentially get denials. But again, the policy flexibilities are largely designed not to give everybody just a blank check, but to create more flexibilities so that there's more of a pay and educate approach.
Senator Adcock, go right ahead.
Thank you. I'm just channeling my inner Representative Blackwell over here. Thank you.
And you're doing a great job, Senator.
Well, thank you so much. I learned from y'all over in the House. Brought it over here with me.
I'm hoping to grow up to be like a senator one day.
Come on over. I got welcomed. You'd be welcomed. Sorry, Mr. Chair. So does that mean they'll have that 90 days, during that transition period when so many things are kind of on a forgiveness situation that they can, those same kind of claims forgiveness or hand-holding or however one wants to put it would be true for that same 90-day transition after the go-live?
Deputy Secretary?
Yeah, Jay Ludlam, DHHS. The light balance I'm trying to strike is that there's not a blank check. There are basic rules that providers need to be following in order to get paid. But generally, we're expecting a significant amount of flexibility early on. And again, I think that this is a way of encouraging other providers to contract with them as these health plans have this claim experience with other providers that it will quickly get around.
Okay. I think this may be my last one, Mr. Chair.
Follow up.
Thank you. It's a combined one. So kind of based on that historical claims testing, the same things that would have gotten thrown out in the past would get flagged during the go-live, right? So that's the blank check piece.
Yeah, Jay Ludlam, DHHS, yes.
Okay,
Yes.
then my last question.
You're recognized.
Thank you. Is what kind of issues do you expect to run into, if any, given that they have to pay 2 different kinds of claims, right? So behavioral health claims now, as well as the physical health, preventive health, whatever, the remainder of those claims. Is there some kind of special built-in way of helping folks adjust to that? Because that's new, right?
Secretary?
Yeah, Jay Ludlam, DHHS. I would expect, by and large, that the health plans would know how to pay a behavioral health claim by now. They've been doing that for a while. So I think that a large focus will be on the physical health claims and making sure that they understand the rules, the policies, and have programmed their systems correctly for that. So I would expect it's in the physical health arena.
Representative Sasser.
Since my colleague asked such a great question, I'm going to follow up a little bit on that question. You were talking about your goal is 10%. Do you feel on the disruption of services, either doctor or care team? Do you feel comfortable with that 90%? And if not, what's the plan to get it to 5%?
Deputy Secretary.
Yeah, J. Ludlam, DHHS. All four of the health plans have cleared the 90%. So all four of them have a disruption of, we need to think of it. Anyway, they are disrupting less than 10%. And I actually share your view. 5% would be good too. I think that the ability to maintain that continuity of care is really what's absolutely critical here.
Follow up? I will just say that even if it's 1%, if you're that 1%, it's 100% to you. So, our goal should be 100% compliance on all of these. Any other questions before we move to the next section? All right. Twice we've mentioned this slide being cool. So Jay, your new name is Jay Cool, and you have to wrap. You have to wrap the healthy opportunities section.
All right,
So,
I got to wrap it. Well, that'll be awkward. Yeah, yeah. Let's not do that. And actually, we'll bring the cool slide back in a second. I want to shift gears. I want to make sure that we give this a moment for what it's worth. And that is that in the end, what we will talk about, we'll talk about the program a little bit, but one thing that we will share at the end is that for pilot participants, we have just completed an interim evaluation review, and what we are seeing is $85 per member per month savings after the cost of service. So that's almost $1,000 per member per year that is saved after factoring in the cost of services. We're also seeing directionally, it's not statistically significant, and if not for the evaluators, I would go bigger on that. But we are seeing also a reduction in emergency room utilization. So there are some really promising results. There are, asterisks and caveats that we are going to continue to pressure test with our evaluators, and there are components of this program that we will continue to look at. But broadly, what we are seeing is that the program is working and is ripe or ready to be brought statewide, like we've asked for in our 1115 waiver. So going back to the beginning, though, the Healthy Opportunity pilots provide an evidence-based intervention using non-medical intervention to address social needs. So in order to qualify for the program, which offers housing, food, transportational, and interpersonal safety services. In order to qualify for the program, people will need 2 medical conditions and 1 social need. This program was approved during the Trump administration, by the Trump administration, and is something that we competitively procured the Healthy Opportunity pilots. They are called network leads, and so we have 3 network leads that cover 33% of North Carolina, or for those of you doing math, it's 33 counties. And these organizations are operating in we call them pilot regions. I'm going to talk a lot about key timeline dates. I do think it's just good to know and maybe be reminded that this program is very young. And so to have these kinds of results so early really points, I think, to some of the promising opportunity for us. Healthy Opportunities is connected to NC Care 360. It is built on many of the same principles and platforms. So we use a social needs screening tool in both the pilots, which is the Medicaid specific, and then NC Care 360, which is kind of the department private-public partnership. We use a similar platform to fulfill the social intervention or the interventions, and so there are commonalities. But for the Healthy Opportunity pilots, which is specific to Medicaid, there's really no wrong door. We've tried to open up as much as possible access for beneficiaries. I think what is key, and we are finding in the evaluation, is the connection to care management. One of the results that is in the report is that the longer you participate in the program, the better, the healthier you become, the better you do. And that means that it's not just about delivering food or housing, it's about all of the other services that a care manager can provide an individual as they do that population health work. This is the slide around what it's cost, and so what we've got here is we've spent about $41 million working with the HSOs. So HSOs, Representative Potts, you didn't catch me on that one. I'll owe you a quarter. Yeah, sorry. Yeah, I can't wait for the PBM slide deck, but. The human service organizations, these are those community-based organizations that are operating in the field, operating within communities. And what we've done here is something that really no state has ever done before. And therefore, we are making investments that are needed in our communities. And so we are helping community-based organizations or human service organizations make investments in themselves. So if they are a food pantry, we are upgrading, helping them upgrade their refrigerator. If they are delivering food, we are providing them with access to the tools that are needed to do that. So we are making investments in community and our HSOs. We have also delivered services, and as you can see, we're I think based on the date of this, we're probably closer to 300,000 services that have been provided or paid for through our Medicaid managed care companies. Actually, my Medicaid managed care companies are probably kicking me under the table. This entire program runs through our standard plans, and we'll be working through our tailored plans soon. So this is really a coordination of efforts. This is that whole person approach, utilizing care management through our managed care organizations. Again, these are just some of the impactful findings and insights that we have seen. Just to hit it one more time, $85 PMPM per member per month. We are saving, and that includes the delivery of these services. Emergency room utilization is going down. And of course, there is just a general reduction in the risk of food insecurity, housing instability, and access to transportation. I think the real benefit of what we're seeing on this slide is that these are benefits coming to the state now. Granted, we need to continue to make investments, but generally we are helping people, helping communities, and improving the health of those individuals. Some things that we need to work on. We need to work on getting the screening to more people. We did find that, not surprisingly, people in healthy opportunity regions are getting screened more. I think based on these results, we'd like to see more. I think also we were a little disappointed that we did not see a large number of pregnant women who are participating in the program. So we'll be doing one of our rapid cycle adjustments and working with the health plans and putting together a program around trying to get more pregnant women screened, understand what's preventing them from getting screened, and then looking for services that we can get to them. So I think that is the conclusion of the healthy opportunities portion.
A couple of questions. So the total spent out of the potential 650 million is 52 million. Did I get that right?
Yeah, so that would be total dollars. What I've got in our slide is just state dollars. So we're probably closer to around 110 million total dollars.
So if I took the 50,585 and divided that into the total spent, I would know how much I spent per year on those folks, right?
Say your math again. I just need to write your formula down.
If you take the whatever it was, 100 million, is that what the number was of the 650, 100 million, and we've serviced 50,585 beneficiaries?
Those are beneficiaries that have been screened for social needs. We've actually served a little over 13,000.
Okay, so divide 13,000 and tell me how much we're spending per person. I'm trying to figure out if I'm a business guy, I always have to figure, yes. I don't spend money, I invest money. So is it a good investment?
Jay Ludlam, DHHS. Healthy Opportunities is a very good investment. Just like, and we've talked about this internally, we are doing something that no other state has done. We are doing something that doesn't exist today. So we are creating bridges that that need to be built over rivers, and we don't calculate necessarily how much the return on investment of that bridge is before the cars have started to go over it. We believe that over time, the investment in community through our strengthening local community-based organizations and health human service organizations is going to be good for North Carolina. We believe that improving the health of individuals to a point where they don't have the risk of a social need, meaning that they are recovering from surgeries more quickly, they're not going to the emergency room. We see real benefits to people and our communities across North Carolina.
When will we know about the approval of the statewide, and at that time, if it is approved, will that also open up the door for some of the other things we talked about, like education and childcare?
Jay Ludlam, DHHS. Our negotiations with our federal partners can take an indefinite amount of time. We have worked closely with them, and we believe that we will hear something in the fall or late summer. So we will know then. We will then need to work with you all in getting additional state dollar funds to be matched with the federal money. So this is not something that is a floodgate moment. This is something that we will want to work closely with you to implement. And from the services, I think you mentioned education and childcare. We are negotiating the services right now with CMS. Yes.
Representative Cunningham, you had a question.
Thank you, Mr. Chair. In the build out of the healthy opportunities, I'm in on it because the recognition that when one walks out of the hospital or whatever institution they're in, they return to their community, and those things are still in their community when they get back. Where does the pharmaceutical play a role as far as if someone's at home and they run out of congestive heart failure medicine, that aspect of transportation?
Deputy Secretary.
Yeah, Jay Ludlam, DHHS. right now, an individual that needs access to medical services like pharmaceuticals would be well within the current program's boundaries to use non-emergency transportation to get there. Where Healthy Opportunities is different is that we are moving more and more people into our communities to recover in our communities and to live meaningful lives in their lives in their communities. And so the way non-emergency transportation works in part in the Healthy Opportunities program is if they need to get to church, now they can use non-emergent the transportation benefit. If they need to go visit family, they can use it for that purpose. It's to alleviate isolation. It's also to create social connections. So an individual in a rural community that might not have a robust transportation network, if they qualify for the service, if they have the medical conditions and they qualify with the social need, they'll be able to repair their car, get their car repaired so that they can be independent, can go to work, continue to participate in their community. So that's in part what the transportation benefit is designed to do. Thank you.
What if they wanted to go to a bar?
It would not. We'll make sure that doesn't qualify. I haven't had that question. Appreciate that.
Thank you.
At a hearing.
Senator Heiss.
They might have friends in low places.
Yes.
Coming in. Just a little bit kind of to the conversation. I have seen Western North Carolina as one of the pilots, 18 counties in Western North Carolina, the Dogwood Trust area. And we really had a tale of two Western North Carolinas. When this kind of came in, Buncombe and Henderson have a lot of human service organizations and those kind of things, close relationships with the Manna Food Banks, those kind of things. The other 16 counties, not so much. The counties I represent, all of them, we have county buses that have taken people to appointments, but there's no public transportation in Midgewood, Avery County and those kind of things. And so it really required starting this from scratch. We did some partnerships and others. And good, better, and different, I think it's why there's a much higher spend than the ratio of spend that went to services, is because in a lot of areas you had to start these kind of things up. I'm a little concerned that in the rest of Medicaid, we're finally getting out of a fee-for-service, but we're coming in Healthy Opportunities and putting another one in place so that the organization's getting paid per box, $6 per box of food when they run it out the door and deliver it. But if you've only got 24 participants right now in Avery County, and now you have to set up a separate office, you have to train somebody to work on NC Care 360, and you can't commingle funds between your other operations, like that's really hard to put together. That's what coming in. And in everything else we're doing in Medicaid, we're going towards per member per month, provide the service, everything else. And then we come along and we jump back in the Medicaid pool and say, we'll pay you per trip or per those kind of things. So I think how we do it, I think the IT system is cumbersome, to say the least, for some of these organizations. But it's not integrated enough in the primary care doctor's office. When they're coming in and they're having the primary care doctor and somebody's got food insecurity, like it's a whole nother referral to a whole nother enrollment to kind of get that off to where it should be a connected others. And then the last thing I want to hit is the positive is this real expansion we've seen of the role of community health workers, to where it's not always having to be dependent on someone being able to get to a primary care doctor and others. We've got someone who can actually go into a home, can assist them with things they're dealing with the home and identify needs like refrigeration for someone who's on insulin, those kind of things kind of within the home, and see how they're storing those. Those compliances are useful, but I think the part we don't have in place is like, what's required to build up these organizations in the remainder of the state, or continue to build them in the current pilot areas, and how do we really get a system that can integrate and function with these things and not be another new system for now we're going to affect every nonprofit in the state's going to have to be able to have someone certified on it to function. But that just kind of my comments, but kind of hitting those areas as we move forward, I'd like to see addressed, if we can get there statewide.
Deputy Secretary, you want to make any comments?
Yeah. First, thank you. Thank you for your involvement in this program and continuing to press the program to be better. First, I also want to thank you also for acknowledging that this is something in some communities didn't exist at all, and that these investments are from scratch, and that's really important. But that they will have longevity within the community, and we are starting to see some of our human service organizations become self-sustainable. The business of they don't need any more startup funds. That they are sustainable within the program itself. Related to funding mechanisms or how we operate, I think that part of the Healthy Opportunities Program is a desire to move to value-based purchasing and other different arrangements, incentivizing health, incentivizing more access to services and care for pregnant individuals, or something like that. There is some flexibility, and now as we emerge from a pilot component of the program to a program with sustainability, I think we're moving to the step of other financial arrangements. And then related to administrative burden, I share that. I share that as an issue for us. Part of it is dictated a little bit by our federal partners. They have put a rigor around this that we feel can be smothering or stifling, and we are working very hard to negotiate that away. We are also evaluating, as part of what we call rapid cycle assessment, we are evaluating where we can be administratively lighter and get people in the program more quickly, get human service organizations paid more quickly, and just focus on improving the health of North Carolinians. So we share that, and we continually look for opportunities to reduce the administrative burden on HSOs and members.
Thank you. At this time, we're going to transition and let our LME MCO CEOs come to the front.
Thank you.
You all bring your name tags up so everybody will know who you are. And we're delighted to have you here. While you're transitioning, I just want to say that you deal with some of the most fragile people in our state. And so we've entrusted you with them and look forward to hearing you talk about it. I'll let everyone introduce themselves, and I think, Rob, were you going first? So go right ahead. We're delighted to have you here today.
Can I get the clicker? All right. Good afternoon, Chairman Burgin, members of the committee. I'm Rob Robinson. I'm the CEO of Alliance Health, one of the 4 public managed care organizations, or LME MCOs, that serve hundreds of thousands of North Carolinians across this state with Medicaid or who are uninsured. I do have my fellow CEO colleagues with me here today, Tracy, Rhett, and Joy, and they will introduce themselves with a little bit more detail here momentarily. On behalf of our 4 organizations, we appreciate the opportunity to present to you this afternoon. We are eager to update this committee on our readiness to launch tailored plans and how the four of us are working closely to improve care for individuals with complex service and support needs. I'd be remiss if I didn't take a moment on behalf of our organizations, the members, families, and providers we serve, to thank this committee and your other colleagues in the General Assembly for expanding Medicaid in North Carolina and for your unprecedented $835 million investment in behavioral health in our state. These historic investments will be transformative for the health and well-being of our citizens and state. Additionally, we appreciate Deputy Secretary Ludlam sharing the department's Taylor Plan overview that you just heard. We shared the department's priority of launching Taylor Plans on July 1st and ensuring the people that we care for have access to whole person care. We'd also like to thank Secretary Kinsley, Deputy Secretary Ludlam, Director Crosby, and their dedicated teams at the Department of Health and Human Services for their partnership on this important work. So we do have a presentation. I'm briefly going to kick it off, but we'll each will be taking a topic. All right, so I've been tasked with just providing a very brief overview of who LME MCOs are. As I said in the beginning, we are public managed care organizations responsible for managing services for people with serious mental illness, substance use disorders, and intellectual and developmental disabilities. And then on July 1st, statewide, we'll be responsible for managing care for people with traumatic brain issues, or TBI. The LME in our name stands for Local Management Entity, and that's about managing care for people who are uninsured, underinsured, and we use state and county dollars to provide those services. MCO, of course, stands for Managed Care Organization, and that's about managing care for people with Medicaid. We are considered a specialized health plan. Essentially, we are tasked with ensuring care for the citizens of North Carolina with the greatest needs. That's where we think our work is done best. That's what we specialize in, and we look forward to continuing to serve this population. We are not a service provider. We contract with a variety of providers who actually delivered the care. Our network of providers is vast. We contract with thousands of providers. These contracts include outpatient therapists, community-based organization, crisis services, and health hospitals and health systems. We are governed by boards that are public bodies made up of county commissioners, members and families, and individuals with the background and experience with the work that we do. We are also advised by Consumer and Family Advisory Committees, or CFAC, as well as our County Commissioner Advisory Committee, otherwise known as CCAP. So the LME MCO model offers the state a couple of things. One is innovative and specialized services that are not traditionally offered within a fee-for-service model. This LME model also provides for predictable Medicaid costs, which I know is important to all of you. And as a government entity, we have a public purpose. Any savings that are generated by the work we do are reinvested back into care. So at the bottom of this slide, you'll see a timeline of the history of the LME MCOs. I am not going to go through that. I'm just going to hit a couple of highlights. As you will see, we've been around a long time, over 50 years. We started off as community mental health centers actually delivering care. We did that work for decades up until 2001, where we transitioned to LMEs. The reason for that, it was found to be a conflict for us to be managing, providing services and managing the funding to deliver that care. So at 2001, we began becoming LMEs, managing the system, and we contracted with private providers. We operated that way until 2012, 2013, when there was an increase in overspend in Medicaid. We were asked to transition to LME MCOs and began managing behavioral health and IDD services for people with Medicaid. And of course, our last iteration is coming up July 1st, where we will transition to become tailored plans, which we are very excited about and well prepared to do so. So there you have it. Everything you need to know about LME MCOs, all in 2 minutes. Here is the slide. You can see Trillium to the right, Alliance dark blue in the middle. Orange Chapel Hill fans won't like those colors. Up to the west is Vaya, and a little bit to the north, and then Partners is left central. And with that, I'm going to turn it over to my colleague Tracy, who's going to talk about what we believe in.
Good afternoon, Mr. Chair, members of the committee. My name is Tracy Hayes. I'm the CEO of Vaya Health. Thank you for having us here today. We wanted to share some of our core beliefs, and I'll start by just saying how much we appreciate all of the General Assembly's support, not just this past session, but in our more than 50-year history. North Carolina has invested heavily in the public system of care for people with behavioral health, IDD, and TBI needs, and we are grateful that North Carolina has continued to support the public system. We are one of only a handful of states remaining in the country that have a public system of care like this, and we believe that public system should be preserved. We believe that we are the best organizers of care to manage this population, this complex population. As Rob mentioned, we offer a number of innovative and specialized services. We have the ability to reinvest our savings back into the community. Most importantly, we are on the ground. We are local in each and every one of your counties, in all of your communities. We have staff living and working in all of the counties that we serve, whether these are care managers or county liaisons who interface directly with county staff to make sure that we are responsive to your needs, or provider network staff who are able to identify in real time what are the gaps and needs in each of your communities. We recognize that a solution that might work, for example, in Graham County is not going to be the solution that works in Wake County, and we want to be responsive to each of your communities at that local level. And so we also, as Rob mentioned, all of our governance structure is designed to ensure that county accountability, that local accountability. We all have county commissioners, county managers, other county representatives who sit on our board. Some of us have established regional boards as we have grown larger to make sure that we maintain that county connection. We also all have Consumer and Family Advisory Committee members who sit on our boards and provide very important feedback to us. And that gets to my last point, which is that one of our core values for all of us is we would echo the CFAC motto, which is nothing about us without us. We try very hard to place the people that we serve at the center and the heart of everything that we do. As I mentioned, they sit on our boards. CFAC members participate in our quality improvement committees. They attend our provider advisory council meetings. They attend regional board meetings. Their feedback to us is incredibly important and vital, that we listen to people with lived experience who are actually receiving the care that we manage. And so these are some of our core values that we wanted to share with you. And I will hand it off to Mr. Melton.
Thank you, Mr. Chair and committee members, and I'll echo my colleagues' appreciation to you all for allowing us to be here as part of your committee today and take this chance just to tell you about where we are and the excitement about going live on July the 30th. You'll see there on this slide, again, you've heard us repeat this, but we know that you all deal with everything across the health continuum. And just to, again, remind you the population that we deal with, Mr. Chair, you talked about the complexities of our members and some of your community's most complex members. And that's who we deal with. That's who we have been dealing with, and we'll continue to deal with those members as we go forward. And again, by definition, that means that those with a behavioral health diagnosis, serious or mental illness, substance use disorder, traumatic brain injury, or those with intellectual and developmental disabilities. So that's, to be a part of our plan, you have to have one of those illnesses to be a part of the tailored plan population going forward. You'll see at the bottom part of that screen just a little bit about the numbers to share with you the magnitude of the work that we're doing. The 4 LMEs will serve over 540,000 Medicaid eligible members, and just to make sure that you understand what that number represents, as Deputy Secretary Ludlam and others were talking about the tailored plan membership, and you saw some of those numbers at the top. We actually operate 2 Medicaid plans. We will operate the tailored plan beginning on July the 1st. We already operate the Medicaid Direct plan. So that those combined numbers for us represent the totality of the Medicaid population that we're responsible for. And you'll see there the other 86,000 state and county funded members. So those other members that don't have coverage, we leverage the money that we get from the General Assembly and from the department on what's called IPRS dollars, state funded dollars, as well as the contributions that are made at the local level, grant money that we're able to get and other to serve those without any other care, without any other funding. So it's important, that second bullet point down there, it's important that members will continue to receive their services and providers will be paid. And just to connect that back to the heat, the cool map, maybe even cold map, I really did appreciate the focusing in on the abrasion potential for both the members and the providers, and recognizing that they're really 2 target audiences of us, and we have to be very mindful about delivering smoothness for both of those sets. For first, ultimately it's all about the members, and then we need to make sure that there's a continuity of services for those individuals, that even if there is a PCP that's not assigned, how do we do a single case agreement with them? How do our member services team help them transition to another PCP if that's their choosing? So it's all about continuity, and we're all fully prepared to make sure that happens. On the provider piece and providers being paid, Partners on that slide that you saw on the cool map was one of those that had identified as potential mild risk for provider concerns over payment. And really what that means for us is that when we began this process several years ago about building our approach to the tailored plan, we partnered with one of the standard plans that already bills and pays providers for physical health care claims in the state right now. And we were leveraging that expertise and combining with our expertise and proficiency in paying the behavioral health claims. We made the decision early on that we were going to continue to operate that way and have the claims go separately. So what will happen on July 1st is, for providers, there's no new abrasion. They'll continue to bill and get paid where they bill and get paid today. Ideally, it would be brought together, and Partners has a plan to do that. But in partnership with the department over the last several months through some of these delays, we jointly agreed that to deploy that solution now before go live might be more disruptive, rather than let people continue to bill and get paid how you're doing it today, and we'll migrate to that single source solution after go live. So that's why we decided to approach that. And then you'll see there the last bullet point, that collectively the size of our budget's managing over $7.3 billion in taxpayer funds, and we recognize that we have a stewardship with that responsibility. And go to the next slide, Rhett. So just again to reiterate, we are prepared to go live. We're excited about going live on July the 1st. We've as Deputy Secretary said, we've passed the readiness reviews, and you're familiar that we've actually passed the re-reviews of the re-reviews of the re-reviews. With each of those delays, we've had reviews, and that's fully tested the system as a result of that, and the ability for us to have multiple chances to test and run our systems. I think that we all feel highly confident and highly prepared about going forward. The networks are there. We'll, as the Deputy Secretary said, and all of us agree, we'll never be done until there's no disruption. That might not be a possibility to be at 100%. That doesn't mean we don't stop trying. And so we all recognize, to your point, if one member is disruptive, that everything else can be perfect, but for that member, that's an issue, and we need to continue to strive towards that. So we have adequate networks now, and we'll continue to build those out and fill in the gaps that are there. We all meet the solvency standards for the state in terms of being an at-risk, fully at-risk managed care plan. We'll continue to pay the claims timely, and a big part of, and you'll hear me talk about this a little bit later on, is the readiness that we've gone through in having the right staff in place. And the challenge that have come with that through the delays and trying to keep staff and staff feeling comfortable about we're going live, doing that through the pandemic, doing that through the workforce challenges that we have today. But overall, we're excited. What we believe is critically important for this state and for us is that we are now transitioning to whole person care. You know, for those members that have had a bifurcated system and have had two different places, we now have the opportunity to fully meet their needs at one place. And address their physical health needs, their behavioral health needs, their pharmacy needs. So this is an exciting time, and we're ready for the challenge and excited to get started.
Good afternoon. Thank you, Mr. Chair, committee members. I'm Joy Futrell, CEO of Trillium Health Resources, and I want to talk today about the work that we've done together. We all have a shared goal to make sure that the people, and again, as everybody has reiterated a few times, those people with the most complex behavioral health, intellectual developmental disabilities, addiction, and TBI needs get their needs met. We all do that throughout those local communities, which are all different, as has been acknowledged today in other areas. Things that work in smaller rural areas like Bladen County won't work in Guilford County, and things that work in Wake won't work in Camden. And so while we want to bring those things that have gone well and the things that haven't gone well, we want to share those so that we don't repeat failures. And I appreciate Deputy Secretary Ludlam acknowledging that today, the work that we've all done together to get to where we are today. We want to continue to work with our providers to standardize when we can. We want to eliminate and reduce those administrative burdens every chance we get, because we know we need them on the ground spending their time providing services to the people in our health plans. We've worked together over the last year with Benchmarks, who represent many of the behavioral health, IDD, and addiction providers. We've worked with them on care management, that was mentioned today. We've worked closely recently with Resource Connections, who represented a lot of the minority providers in North Carolina, to make sure we're all talking with them with one voice, and we want to support them. We'll continue our work with the North Carolina Medical Society as we move into tailored plans, making sure we can ease those administrative burdens for those primary care and specialty providers that work with them. So to formalize that relationship that you've heard about today, that collaborative approach that we have formally formed the North Carolina Association for Public Community Health Plans. I think many of you know our leader in that, our association representative, is Dave Richard, who has worked with us collaboratively to make sure we understand all aspects of the healthcare in North Carolina. And we look forward to continuing to work with you all on creative solutions to ensure that our public system addresses the need of the people in our plans in all 100 counties throughout North Carolina.
Go to the next slide. All right, Tracy Hayes, Vaya Health. We're each going to spend just a few minutes with a few slides sharing some of the specifics of our organization and some highlights of some accomplishments or recent initiatives. So you can see there the map for Vaya Health. We've got a big chunk of the western part of the state, and then we picked up 9 counties during the merger with Cardinal, and so you see the other blue area there, and then most recently have added Rockingham County, so for a total of 32 counties that Vaya manages in North Carolina. We have a 21-member board. We have an alternative board structure approved by Secretary. It was actually approved by a former Secretary. And we have 4 regional boards, and those regional boards meet quarterly. Each regional board appoints 2 members to the governing board, and every county appoints 2 individuals to the regional board. This is how we ensure that every county is represented in our governance. Those regional boards, as I said, meet quarterly, and we're actually going to be having those meetings tomorrow and Thursday. So I will be in, Burlington, Lenoir, Asheville, and Silva for regional board meetings over the next 2 days. On our board, of course, we also include CFAC members. We have traditionally 4 CFAC members on our board, representing each of our 4 regional CFACs. And go ahead and go to the next slide. So one of the things I wanted to share with you all, and I think it's timely in response to some of the questions that were raised earlier, is about some of our efforts to build that statewide network. You heard Deputy Secretary Ludlam talk about how all of us have reached that 90% threshold. I think I can speak for all of us when I say like 90% is not good enough. We are all striving, and several of us have surpassed that, and we are all striving to get to the 100%, Senator Burgin, that you referenced. And we are continuing to work with health plans across the state. Vaya is currently contracted with every major health plan save one, and we are in the final negotiations with that health plan and should have that wrapped up within the next week or so. So you can see there we've got contracts with 74 hospital and health systems in the state, over 15,000 primary care physicians, almost 11,000 specialists, over 1,400 behavioral health entities providing care at nearly 10,000 different locations, and 328 innovations providers. We have also done a significant amount of work to expand access to crisis care. We are extremely grateful for the investment in behavioral health that we saw in the last budget, which includes $80 million for expansion of the crisis services continuum over this past year and this coming year. And we're looking forward to working with the department to implement those funds in our county. Some of the work that we have done, Vaya has an open access walk-in facility available in all of our original 31 counties, and we are building that in Rockingham County right now. So what that means is somebody can walk in to a provider when they need care. We also ensure that all of our contracts with our crisis providers specify that they cannot turn anyone away based on source of funding or where they live. So if somebody from one of Joy's counties is traveling and is in crisis in a county that we manage, they can walk into a crisis center and be served. We never want to have those barriers just based on where someone lives or where their funding source comes from. You can go to the next slide. Two of the recent projects that I wanted to highlight for you all to kind of emphasize some of the work that we have done to really strengthen our communities. One of them has to do with working with our DSS agencies around children in foster care. We have been working collaboratively with Benchmarks on a program that we call Pathways to Permanency. This has been a 2-year project that has involved representatives from Vaya, from local DSS agencies, DSS directors, DSS social workers, Benchmarks, providers, and most importantly, foster care families themselves, people with lived experience who can sit at the table and tell us, here is what has been working for us and here is what is not working for us. And these folks have gotten together and worked very hard on developing real-time solutions to the barriers that exist for children in foster care. We are seeing, I think as most of you know, incredibly high percentages and numbers of kids in foster care across our state. The project culminated with one of the recommendations from the group is we need more foster parents. There are not enough people in North Carolina right now signing up to be foster parents. So we worked with Benchmarks to create what we call the Adventure Awaits campaign. This was a social media campaign that ran for 2 months in January and February of this year and featured video clips from, again, real live foster parents talking about what an adventure it has been to be a foster parent, the reward that it has brought to their lives, and encouraging more families to consider becoming foster parents. This campaign reached over 500,000 people, and we are very hopeful that this will help encourage more families to be willing to become foster parents. Another program that we have spent a lot of time and work on are our community transition programs. That includes transitions to community living, which I think you've probably heard about from Deputy Secretary Ludlam and others in prior presentations. That resulted from a settlement with the U.S. Department of Justice around diverting individuals away from assisted living facilities and adult care homes and to keep them in the community. Vaya has been very successful in that program. We have placed over 1,000 individuals. We were recognized by the independent reviewer in the 2023 annual report on the TCL program. One of our recent community transition programs that I wanted to highlight for you is something we are doing with the Department of Adult Corrections. This program just started last year. We've received 12 referrals. This is to help individuals who are being released from incarceration navigate that transition back into the community. And I can give you one example, of course, without sharing any names, but we did have an individual we supported recently who was released from incarceration. Through this DAC program, we were able to connect this individual with supported employment at a bakery. They were able to gain good employment, get solid housing, get connected to get their Medicaid set up, and they are doing very well 6 months into the program. So this is sort of a pilot program that we are hopeful that we'll be able to expand more into the future. So those are just some of the examples of things that we have done at Vaya to help support our communities.
Mr. Chair, Rhett Melton, CEO of Partners. Just a couple of things to bring your attention to what Partners is all about and who we are. You can see there on the map what the counties that we cover, the 15 counties, and some of the key points of information are there on the left. Total population of over 2 million, Medicaid lives, again, combined between the Medicaid direct population and the Tater Plan population of 102. You'll see there that we serve a little over 15,000 members annually through that state fund and county fund bucket that I mentioned earlier, just north of $1.5 billion budget. 4,300 provider contracts are in place, and again, that's contracts, so large health system counts as one in that, but there's a lot of providers, specialists, and others. As Tracy mentioned, a contract means the signature page, but all the providers that fall under that signature page, so the network is far broader than 4,300. And we currently have a 25-member board of directors. Partners has maintained through the consolidations and through the expansion, one member from every county on our board. That's written into our bylaws. So every county commissioner has a seat on our board or their designee. I think of the 15 counties, 12, I believe, have a county commissioner and 3 have appointed a designee to the board, but all have that slot available to use at their discretion. And then a couple of accomplishments I just wanted to call out to bring your attention to, the things that we've got going on that certainly I'm proud of. This first is the continued move towards using technology to better serve our population. So in addition to the things that you would see from an outsider looking in, the web portal and some of the things to navigate and find information, the member portals and others, there's a particular application that we partnered with a vendor, Pix Health, several years ago. This was their first entree into serving the behavioral health population. And what it is, it's an application that gets loaded onto their phones that really is a way to maintain contact with that member, to give them updates, to check in with them, to have them have an opportunity to connect with a live care management type of a person to help them navigate. Some of those are peer related. And what we've shown is for many of our members, again, that connectedness is very critical, right? When they're in during the day in that formal service setting or between appointments, our members need to have a sense of, I've got somebody that's connected with me. I've got somebody that's helping me through this journey. And that's what this Pix Health app is designed to do. And some of the data that we see internally about the benefits of that, one of the indicators that you see monthly on the Tater Plan report card is the timely follow-up from members discharging from an inpatient setting. And you're familiar with that report to know that the state goal is to have 40% of those members followed up on within 7 days. And that's about where the statewide number is. One of the things that we've seen is the members that we have engaged through this Pix Health app are 68% compliant with that 7-day follow-up. So it's a point of connection that shows that gets people back into those follow-up appointments. A particular subset of that's critical, I believe, is the most significantly needy, if you will, or those with the most severe illnesses within our population are at 85% compliance. So that's a very, very telling thing about how the importance of this. So I put this up here not only to brag a little bit about the success that this program has had and to compliment our peer, the Pix Health app that have partnered on this along with us, but also just a broader comment about, our space, the behavioral health space is typically not known for using technology as much as the physical health space. And there's real opportunity for us to leverage all the new advances in technology to better serve our members with their behavioral health needs. And this is just one example of how we need to do that. And go on to the next slide, if you will, Rob. I mentioned earlier, Partners is very deliberate about our culture and very deliberate about our workforce development. And on the surface, you might say, well, that's not something that we see like the Pix Health app would be or like some of the other services. And I would argue that that's what you see in us every day. Because that's what drives every member of Partners team to serve their members. So we've been very deliberate with all the workforce challenges that are going on, the recruiting challenges, the retention challenges, the remote work challenges. We've been very deliberate about building that workforce up and staying connected. One of the things that companies often do is they do exit interviews. And they pay attention to somebody when they're leaving, like, tell me why you're leaving. That's too late. And so Partners implemented a plan this year where we did 100% of our employees, we did stay interviews. So we connected with them during their employment and talked about what motivates you to stay. Have you thought about leaving? Why would you think about leaving? What can we do to make your experience and your journey with Partners more enjoyable and rewarding for you? So a very strong commitment to making sure that we keep a stable workforce. We've implemented this year a training that we've still got a couple of sessions going on. We're at 95% completion right now of all of our employees to bring the power of positive leadership to all of our workforce. And leadership doesn't mean that the supervisors of the organization, everybody's a leader, because a leader means you're influencing somebody else. And our receptionist is a leader. You know, our physical ops staff is our leaders because they're influencing other people. So one of the things that we're doing this year was we're being very deliberate about making sure that there is a positivity about their day. And how we complement Partners' work with what their goals are in their individual life. So a lot of work there. And then the next last bullet point that you see there is a culture exemplars core group. So we've identified throughout our organization the people that really exemplify Partners' culture, that kind of exude the characteristics that we want to be known for. And we're using them to help build that culture within everything that we do. That's how we recruit. Those are the characteristics that we're recruiting for. That's how we're rewarding. That's how we're recognizing. And so all those things kind of tie in. So again, that's not necessarily visible to you in terms of a program, but I would argue, again, this is the root of every fruit that you see that comes out of Partners. And I think it's critical that we focus on this. And the last point there is, again, Mr. Chair, I will say thank you to this. When I had the chance to come before this committee last year, I talked about some challenges that we had in getting major health systems signed up with us, and you offered your help and jumped in and helped. I appreciate that. The secretary jumped in and helped us as well. Our team had laid a lot of groundwork, and that helped us to get us over. So Partners is in very good shape right now. As Tracy said, we've exceeded the 90%. Partners right now is at a little over 93.5%. We actually are at 95, we believe. But what happens is when we sign a contract with a health system like an Atrium, and that's one contract, and now we're loading all the individual providers, and not all of the PCPs have fully been loaded yet. So we know we're at 93 plus, we believe we're at 95, and we're continuing to march towards 100. So that's a significant change from where we were last year. So again, thank you for that.
They're the counties that Alliance serves. I can actually read mine. I've only got 7, not like the empires these guys got with all the counties they have. So under Alliance is Mecklenburg, Orange, Durham, Wake, Johnston, Harnett, and Cumberland. As I think you know, all those counties, we primarily serve within an urban setting. Thank goodness for Harnett, who joined us recently to bring in a little diversity. Bringing in a rural county. You can see the size. We have 137,000 Medicaid lives with a total population of 3.5. Oops. How do you go back? All right. The accomplishment I want to talk about is our work that we've done to improve care for youth involved with DSS. I know this committee is very aware that there's been a crisis in this state. It's not only in this state, it's across the country, resulting in kids sleeping and living in DSS offices. It's really difficult to believe that this day and age that still happens. There's probably, a couple of reasons for it: lack of provider capacity, lack of foster care, kids. We've seen a significant increase in number of kids seeking services. There's probably bits and pieces to all of that. So we decided that we were going to try to address this in partnership with some of our counties and our providers. Again, we didn't think we could do this ourselves, but man, we were going to take a really good stab at it. So we created a service expansion plan for these kids, invested over $22 to see if we could put a dent in the number of kids in DSS offices. I'm just going to hit some of the highlights of the programs. The plan included prevention, early intervention. It included crisis services, residential, as well as other best practice outpatient programs. First thing we did was create a care management division that solely worked with youth involved with DSS. That team is now 50 members strong, and their sole job is to seek appropriate treatment for kids involved in foster care. I just want to make a comment on how proud I am of that team. It's got to be a really difficult and challenging day when you spend all day and every single provider says no to these kids with very severe and complex needs, but they hang in there and they are making a difference. The other thing we've done is opened up new crisis stabilization transitional programs. These are new crisis beds designed to be short-term, where a kid in DSS who is experiencing a behavioral health crisis doesn't need to go to the hospital, can be admitted to one of these programs. We've built 55 of these beds over the course of the past couple of years. We've tied these to contracts with the providers to value-based payments. If you can keep these kids, take these kids, you get an incentive to, we'll pay you to do that. The other thing we've done is open up the Hope Center in Fuquay. This is our child crisis facility. It has 8 chairs where kids can come in, get screened, assessed, provided medication, see a doctor, hopefully go back home. And very soon, the 16-bed piece of that residential bed will be opening. Another project to help address this issue is that Alliance partnered with Mecklenburg County, the Steve Smith Foundation, and Daymark, the provider, to develop a 24/7 walk-in facility in Charlotte. In that facility, kids, adults can walk in, be seen as seen, screened, assessed, be seen by a doctor, provided short-term treatment, and then go home with a script connected to next level services. And the last piece of this is that I'm going to share is the MORS program. Deputy Secretary Ludlam talked about that MORS program. This is a specialized mobile crisis. MORS team will stay with the family until they're actually connected to services. So we did all that work. So what are the outcomes of it? When we started this, we were averaging about 16 kids a month in DSS offices, which is way, way too many. We had a high of 1 month of 26 youth sleeping in a DSS office. Through our efforts, we've got it down to about 9 per month, but that's over the course of the year. The number continues to decline as we open up and more programs. As of March 28th, last week, we had 3 kids in DSS. And over the course of the past 2 or 3 months, there's been plenty of periods when there's been no kids in DSS. We're not done yet. I'd like to get to 0 before the Child and Family Specialty Plan takes over. But that's our work that is, again, at the highest priority being managed, including our board. All right, Joy.
Thank you. Joy Futrell, Trillium Health Resources. So as you can see from the map, and as many of you probably know, we had a large consolidation that occurred on January 1. Thanks to a great group of dedicated teams, we were able to pull that off in 45 days. Large footprint covering managed care throughout North Carolina. And so what you see on that map is the 5 regions that we've designed. we wanted to make sure that every single county, whether you're a large county or you're a small county, whether you're Terrell or whether you're Guilford, that you have the same opportunity and the same voice at that table. And so, like Tracy, we have the regional advisory boards in our area to make sure that every single county has representation. So in our case, these regions are aligned, similar cultures, similar size. Every single county has the opportunity to appoint one county commissioner and one other designee. They could be somebody with some kind of healthcare expertise, lawyer, other things that are defined in 122C. And then each of those regional advisory boards that exist in those regions appoint members to our governing board. So each regional advisory board appoints one county commissioner and two other individuals up to our governing board. As Tracy mentioned, we have the same philosophy about CFAC. We want to make sure we have that voice of that lived experience at our table. Why would we sit around and make decisions about people without them? So we want them there too. So in each of those regions, we have a CFAC, and either the CFAC chair or a designee also serves on our advisory board. And then in addition to that, the provider council reps. Today is day 62 of that consolidation. And so for providers and members, we wanted to make sure throughout that consolidation that people didn't lose their access. So similar to launching the tailored plan, our goal was to make sure every single person could see their same provider on February 1st that they saw the end of January. We had a lot of words of comfort for people as we moved through that. We had two slogans. It was members first about everything and grace to each other, because we knew in that fast, hectic time span, there'd be a lot of stress, people really trying to get things done. And even though we wanted to get it right, clearly there were errors and glitches that came up, but we had people standing by dedicated to make sure those issues were addressed. We honored all provider contracts, every site that they had. If they had a contract with East Point or Sand Hills, we honored all those contracts, and we've honored all those rates. And I want to say now, I appreciate all of you and the entire General Assembly for those enhancements that you made in our rates. It was at a very pivotal time for us, so it was a good message to carry throughout all the chaos to be able to increase some of those rates. The next thing, our second goal is tailored plan launch that we've talked about today. And again, as others have said, we want to make sure that people have that continuity of care and that they can continue to see that same PCP. I'd already written this in my notes before you ever said it, Chairman Burgin, but we're not finished until we get to 100%. And as you said, one person that doesn't have it is a big deal to that one person, and we want to fix it for them. So we'll continue that work and working with the health systems and working with those primary care providers to make sure that we get them all contracted. With 88 days, if I did the calendar count, from today, we'll launch those tailored plans. Talk a little bit about the things we've done in our community. I want to highlight just 3 of the programs we've developed, really to increase access to services in our community. As you all know, North Carolina's been grappling with significant drug, alcohol addiction crisis, which not only has negative impacts on those individuals, their families, our communities. Alcohol abuse, I read last week, costs North Carolina about $7 billion a year. So with this healing place in New Hanover County, it was a partnership that we did with the county. It supports long-term recovery, and that's one way that we can address that crisis. It was based on a model replicated out of Kentucky, and a long-term peer-led recovery model. Has 100 beds for males and 100 beds for females, in addition to 20 social setting detox beds. It also has an overnight homeless shelter that people can come and check into at night. Second thing I want to talk about, and I heard this morning Director Crosby talk a little bit about mobile crisis as one way to respond to crisis in the communities. You know, while that's 100% true, we also looked at these mobile clinics for another reason. I've heard today a little bit of the discussion about the differences in what works in urban areas and what works in rural areas. And with these mobile crisis clinics, they go to the people. And so when you're in a rural area, that as a provider, you might not have as many people every square mile. And so it's always not as cost effective to rent office space to see those few people. And so one of the first ones of these we did, was down in Perquimans County, where a provider actually lost their space. The health department was expanding and they needed more of their space back. And so we had to come up with an innovative way for those same people to be able to access services. And so we looked at mobile crisis. Today we have 13 of these mobile clinics across our area. We have agreements with providers like Monarch, RHA, Port Health, Waynesboro Family Clinic, and we will certainly continue to look at these to see if they are things that we can expand into some of our new counties as we move forward. And the last one I want to talk about is probably addresses an issue that we've probably all encountered at some point. I'm sure you all, as legislators, have. We've got, I think it's about 15,000 people on the innovations waiver. I might not have that number exactly right, but close to that, but more than that waiting. I believe about 17,000 people waiting for those slots on that waiver. We have at Trillium about 4,800 slots and 5,300 people waiting. People wait an average of 10 to 12 years to get one of those slots. That's far too long. Thank you so much for the slots that you allocated and that you all have done every session, allocating us some slots, because every single person that we can move from that wait list to that slot makes a big difference in their lives. So we want to make sure as people wait for the innovations waiver, they can access other services, whether that's through state funds, Medicaid funds, such as what we've had B3 and I-option services, I believe will increase that even more. And this transition to employment service is one of those that we're able to offer. We do that through a partnership with Easter Seals UCP to make sure that people that are waiting, that have intellectual and developmental disabilities, are supported as they wait for that innovation slot. We will certainly continue to strengthen the access of services through innovative developments and partnerships with our providers across all 46 counties to make sure that we support people to live safely and to live their most healthy life. I'll turn it back over to Rob.
All right, that concludes our formal presentation. Up on the board, of course, is our names and our phone numbers. We all would encourage you, if you have questions, comments, issues in your communities, to please reach out to us. We are more than happy to hear those kinds of things from you. Mr. Chair, before closing, I have a special announcement to make, if that would be okay.
Yes, sir, go ahead.
My friend and colleague, Mr. Rhett Melton, has decided to hang up the cleats and retire at the end of July. I know many of you have got to know Rhett, and I don't think you'll find anyone more committed to this work than he is. His contributions to partners and to the system overall are numerous, and it's very easy for me to say he will definitely be missed. Would it be okay, sir, if he could say a few words?
Yes, sir. I recognize Mr. Melton. You please feel free to talk to us.
Thank you, Mr. Chair. And, Mr. Chair, before the meeting, I mentioned about Chapter 2 and shared, you and I have had a lot of conversations over the last couple of years about what's important to us and family. And so as I shared with our board of directors when I told them a couple of weeks ago that I was going to be retiring, I shared with them that I remember a day very vividly, and it was August the 4th of 1999, and it was a Thursday. And I'm sitting in a hotel in Atlanta, Georgia, and chasing a job, started a new job, and sat there and I thought, what am I doing? Why am I here? I had a wife back in Charlotte, had a 3-year-old son back there in Charlotte, and my wife was pregnant with our second son. He was about 3 weeks away from being born. And I wondered what I was doing at this hotel in Atlanta rather than there. And so for me that day, I wrote down on a piece of paper I took out of the desk drawer there at the hotel, I wrote down a word that became my life word, and that's priorities. And I wrote up under that, I wrote 6 things that still are my priorities today. And I wrote down 6 words. I wrote down faith. I wrote down Jenny, that's my wife. I wrote down Justin, my oldest son. I wrote down Tyler, my son-to-be. We already had his name picked out. I wrote down relationships, and I wrote down integrity. And so for me, the last 25 years have been about those things. And over the last couple of years, a lot of changes in our life, growth in our life with family and the marriage of our boys and grandkids coming, losses in our life in terms of parents and siblings that have passed away, and have really decided that now is the time to rededicate towards those 6 words. And so I'm excited about that. I'm excited about what Partners has accomplished. As I shared with our Partners team, we have lived our mission about improving lives and strengthening communities. And so I'm proud of that. I'm proud of the team, the 900 plus staff that we hired. I've had a front row seat at the best and watching true experts dedicated to this population serve. And I'm proud of the integrity that we've done it. There are people that there may be some in the back of the room that would say, like, I haven't liked all the decisions that they've made, but I don't know that many would say they did it with poor integrity or lack of integrity. So I'm proud of that. Partners is well positioned. I'll be here through the transition, and I'm excited about that. And then Partners will be led not to continue to do what we've done, but something very better, something much better, something much more noble. Again, the Tater Plan work is awesome. What we're going to be able to do in the lives of our members is incredible. So I look forward to that. I look forward to a smooth transition from our board to the next CEO, and look forward to staying in touch with everybody in this space to see what's ahead as we serve the citizens of North Carolina. So thank you for that, Mr. Chair.
Rhett, on behalf of the state, I want to thank you and all the leadership at Partners and what you've done for all the folks that you've touched. Now, I always say the word retire is not in the Bible, so I'm going to appoint you to be the concierge for those 10% that we need to serve, because you know how to do it, so you need to provide concierge service to those 10%. I think that'd be a good task. So, I know we're way behind, but I think people needed to have opportunity to say some things. Questions? Senator Adcock.
Thank y'all so much. Your passion for this work comes through, and I really appreciate the thoughtful way you presented that information on behalf of your entire networks and your organizations, and behalf on the patients, the families that you serve. So I just wanted to say that. And then ask a question. When we talk about 10% or less disruption, I realize that's probably an average. So, we know that people need more. The people that you care for, or that you make sure get cared for, have primary care needs. They have behavioral health, substance abuse, all those. But they also probably maybe have some home health needs and other needs. So is that disruption, even though it may average 10% for someone, is that disruption different is it higher in primary care? Is it higher in home care? Is it lower in physical therapy or things? Can you give us an idea of what the range is for disruption, if the average is 10% or less? Or is that a fair question? I know this is a question that some folks who are representing the disability community are interested in.
Rhett Melton, CEO for Partners. Thank you for the question. When we talk about that number, what we're measuring is the primary care disruption. So that it's not an average across all specialties or disability. That really is measuring just the disruption for their PCP, for the primary care physician assignment. So you're absolutely right. And we have Partners team members. We have Partners team members on our executive team that are more concerned about those specialists, to your point. So that's not something, though, that is part of this 10%.
Follow up.
Thank you very much, Mr. Chair. So here's just a quick follow-up. So as primary care provider, since we know that it's not just physicians, our wonderful physician colleagues providing primary care out there as a nurse practitioner, I, of course, have to say that. It's in my job description. But so that means that it could be higher in like physical therapy as well as the medical specialties and things like that. So that I think that's a great clarification. I really appreciate that disruption percentages for primary care, and that there may be higher percentages in some other areas in which they need care. And we need to think about that, because if you're basically a healthy person but for your congestive heart failure, and you're disrupted with your cardiologist, that's a problem. If you've got cancer and you're disrupted from your oncology team, that's a problem, right?
Mr. Melton?
Thank you again, Rhett Melton, CEO for Partners. Great question, and absolutely one that we need to be paying attention, and we are paying attention to it. So while it could be higher than the 10%, it often could be lower because some of those specialists we might be more successful at. There's not as broad of a population of pediatric, dialysis, but also appreciate you calling me out for PCP care. Can be my son married now I call her daughter who is going to PA school. So you're absolutely right. I understand that there's a lot of care providers beyond the doctor title.
Representative Cunningham.
Thank you, Mr. Chair. So I listened and I heard CFAC, I heard hiring practices, I heard minority providers, but I didn't hear anything on autism. And that's something that's still prevalent in that space that you all have the responsibility to provide services for as well. I'm going to make a remark and then I'm going to stop. I don't know Mr. Rob Robinson. I've met you, but I know your staff. And since being in Mecklenburg County, if I pick up that phone and I call about anybody over in the emergency room waiting, I get a call back and I get an answer. And it may not be quick for the solution, but your staff speaks volume to who you are in your leadership. And I wanted to say that here today. Thank you, Mr. Chair.
Thank you. Representative Blackwell.
Thank you, Mr. Chairman. One, if I may say, it may be standard practice with a lot of businesses, but I was impressed with the stay interviews, with the problems we're having with staffing. It seems to me that's very proactive in getting started and not figuring out why they're leaving, but trying to work with getting them to stay. So I'm impressed with that. But I have two questions. Is it Futrell or Futrell or Futrell?
Futrell.
Okay. Two about topics that you mentioned. First, you mentioned the healing place in Wilmington. Is that financed at all with contributions from opioid settlement dollars or the funding coming from elsewhere?
Ms. Futrell.
Thank you, Mr. Chair. Joy Futrell, CEO, Trillium Health Resources. That is primarily financed by New Hanover County, financed a lot of that through a debt. And then the beds, the 200 beds are primarily financed by county ABC funds. And the 20 detox beds are financed primarily through Medicaid funding.
So is it limited to New Hanover?
No, it is not. No,
they take folks from other counties.
Many surrounding counties.
Who then contribute. You mentioned, I think you were working with an organization from Kentucky. I've heard about an organization from Kentucky doing something similar. And their model, as I recall, it focuses on a longer term relationship to try to assure that people are not just clean, but that they have established jobs and homes to go to before they put them back out. And I don't know if that's a part of the program, but one way or the other, I hope, since you've only been in operation for, I guess, just a year or just under it, I hope somebody is keeping some good data on the people you're working with so we can be told whether they're staying clean and staying employed and staying housed and so forth. And one final thing.
Yes, sir.
You mentioned you had over 5,000 on the waiting list for innovation waivers. If you had more slots, do you have the means to serve the additional people on the waiting list? How many could you serve if you had the, I've been told, I think, that we have a problem that we don't have providers even if we had the slots. So I'm always trying to get an idea of whether we've got room that we could serve more than we are or if we're sort of stuck where we are.
Ms. Futrell, and when you answer that, how many of those 5,000 are getting some services? They might not get the full innovation waiver, but they're getting some services.
Yes, sir. Thank you. Joy Futrell, CEO, Trillium Health Resources. Great question. So today, to answer your question and Representative Blackwell's at the same time, about 68% of our people on the wait list, I will say prior to consolidation at Trillium, were receiving some service. So there are direct service personnel and people out there providing those services to them. I think it's about 59 or 60% with consolidation. So we want to work to get that back up. I think there's other things besides direct staff that can provide that. We're looking at technology and other ways to leverage that so that people who live independently can get services that maybe don't require a direct person to sit there with them other days. But the direct care worker shortage is certainly a true thing. Those increased rates absolutely help that, but there is still a shortage that we and our providers experience like others in North Carolina.
Senator Hayes.
Thank you, Mr. Chairman. I guess to start with, probably to not surprise many people, I have a very different view on whether we should have set limits for what percentage of contracts should have been required to be in place. And I think there may be some long-term implications on that, particularly in areas of the states where we literally saw LME MCOs that were not financially solvent because of the contracts that they were in and the rates, and for then us to come in and say as a state you have to pay 90% of those rates or contract with 90% of those entities is concerning to me. But here's where we are, and here's where I hope we're successful. We chose the wrong number of LME MCOs to begin with. I think we started at about 15 and eventually narrowed it down to 11, although some had to consolidate themselves for embezzlement and other reasons. But we came down to 8. We came down to, now we're at 4. And I think all 4 have a sufficient population size to be able to deal with risk. We had several in the last iteration that were too small, and a high-cost patient meant challenges to the financial solvency of the others. We've had all kinds of conflicts about how much is an appropriate fund balance and others, and some of you may remember when, the RAN and the LME MCOs wound up with a larger fund balance in the state of North Carolina. We've at least fixed the North Carolina side of that kind of development with our rainy day fund and others. So what I want to get at is this structure of 4 LME MCOs, and I think if I remember correct, we're talking about a 4-year timeline for these contracts when the plans go live. Is it solvent for the 4 years, and does it place the LME MCOs in a position to be able to bid for these services in the future?
Mr. Melton, you answer that.
I'll try. Senator Hayes, thanks for the question. Rhett Melton, the CEO for Partners. I do think that there's, I think that we're all strong. I think that we're all financially solvent. I think that we're all actually the coalition that we talked about earlier, the United Together, is going to make us even stronger. I'm proud and was happy to hear Deputy Secretary Ludlam talk about, kind of a last minute information technology solution that we came up with to solve a challenging problem, and the new chemistry that's amongst us. We readily gave the code away to our peers so that everybody could be. That's the type of cooperation that's going to make the state successful with these. I do think that we always also have to have in the conversation when we talk about how many. You saw Rob earlier kind of walk through the 50 plus years on the timeline. The thing that makes North Carolina's model so successful, in my opinion, and I've been here since 2000, and the thing that makes it unique is the wisdom of the policymakers for decades to say this population is best served locally. This population is best served when you're in those counties, when Gaston County is different from Forsyth, is different from Wake. So when you have those, so I always want us to be mindful of there is such a thing as too few, in my opinion, because you move away from that local connection that we have with our departments of social services and our health departments and our county commissioners and the local clergy community, local United Way. So I think this is where we are. I personally would rather, have smaller groups, but this is it. I would not be a fan of seeing it shrink down more, because I think we're in that spot now to where we can be local, we can serve those members, and we're at a point that we can be financially healthy in doing that, to your question, and maintain the necessary funding to cover the risk of some of those high challenging cases.
Senator Zari.
Thank you, Mr. Chair. I wanted to talk about the patients or the members are going to be enrolled here shortly. I think I saw the number was about 500,000. And going back to Deputy Secretary's chart, his cool chart he talked about earlier, one thing I saw consistent across the board was that all the providers, with the exception of Partners, was expecting some form, I think the term was mild abrasion, with respect to the calling and getting appointments and services, specifically for non-emergency medical transportation. And I'm wondering, not just with the transportation, but across the board, are there any expectations for disruption for call centers or appointments or seeking to provide those services? And is that a problem that we see going into this? And how are your organizations handling that training process for customer service?
I'm going to just start picking people. Ms. Hayes, why don't you answer that?
Yes, thank you. Tracy Hayes, Vaya Health. We are all preparing our call centers for what we anticipate will be a significant increase in call volume. This will not be the first time that we have had this type of experience. We all have call centers that have gone through multiple, for example, mergers, and we have all prepared those call centers to be ready and able to take a much larger volume of questions. We provide them with talking points. We work with the department provides specific talking points. We do a lot of education and training both for the call center and for the care managers who are actually directly interfacing with these members. And I think that's one piece that people don't always think about. They think about, they're going to pick up the phone and call a call center. Often the first thing a member is going to do, or a member's family, they're going to ask their care manager, because their care manager is the person who's working with them on a daily or weekly basis to help them actually navigate their care plan, figure out what are the right services for them, who do they need to, how do they get linked to the specialist care that they need. So often what we see is they will reach out to their care manager even sometimes before they will call the call center. But we definitely know that when the letters go out, you heard Deputy Secretary Ludlam talk about, he had a timeline up on the screen of, and there's going to be letters mailed. We all know when that date is. We all know that we will get an increase in volume of calls as soon as those letters are mailed out. And actually, some of those letters have gone out once or twice before because of the delays. And so our staff have already kind of had fire drills with this, where they've already received calls about the packets and the letters that were mailed. And so they are well prepared to handle that influx and that additional volume of calls.
Okay, we're going to go up into hurry up offense. So we've got two more questions, then we're going to switch over to Deputy Secretary Ludlam, and I'm going to say we're going to be done at 3:30. I know that's a little longer than we're going to go, but Chair Potts.
Without proper transportation, even the best medical care goes unused and to waste. What are you doing to invest and create more non-emergency transportation for your clients?
Ms. Futrell, you answer that.
Yes, sir. Thank you, Mr. Chair. Thank you for the question, Representative Potts. Joy Futrell, CEO, Trillium Health Resources. So in this case, our first goal out of the gate is to stabilize what is there. So as Secretary Deputy Ludlam talked about earlier, it's that ambulance piece of the transportation. It's a little more complicated because you're dealing with franchises for those in counties. So our vendor, and I believe it's the same vendor that every health plan in North Carolina with Medicaid uses today, Motive Care, is working with our teams to work with those counties to make sure we can get those contracts in place and that people are able to access the transportation they need. We're also making sure we identify who those people are so that we understand why they need that transportation and we can make sure they get it in some way.
Representative Baker. Follow up. Sorry, excuse me. Follow up.
When is this going to happen?
We are working on that right now. I have teams working on that today.
Thank you, sir. Representative Baker.
Thank you, Mr. Chair, and I'll try and be brief. I just wanted to say thank you and compliment you all. I feel like you have managed enormous structural changes with constantly changing unknowns as well. As a unit, while still caring for the most fragile patients we have in our state. So I want to thank you for that. I think that culture starts at the leadership level, and I think that you all have demonstrated that you've implemented that. I want to specifically, as representative for Cabarrus County, talk to Rhett and thank you so much for your service. I can speak for our county in saying that your priority of relationship, and I've seen that in all of you as you've managed this transition, prioritizing relationship, bringing your skill level, then prioritizing relationship on a local level has been game-changing for our patients. And we have sustained in Cabarrus County enormous transitions with ongoing services. And I just think it needs to be brought to light what a task that has been. And thank you for the patients who depend on your efforts every day. Thank you so much.
Thank you. You all stay right there. Deputy Secretary Ludlam, move on up to the front here if you want to. And so what I've heard from all four of you is you are ready for July 1st. Is that right?
Yes, sir.
That's what I wanted to hear. Deputy Secretary, we're going to let you wind us up. I'm sorry to have infringed on your time, but I know how, since you're Cool J now, I know you can do this quickly.
Well, this... Apologies. Good afternoon, everybody. My name is Jay Ludlam, Deputy Secretary, North Carolina Medicaid. Cool Jay. So this is, as part of our readiness work that we did with the health plans, we did validate that they're financially ready. And of course, like the standard plans, we will be establishing actuarially sound rates for the tailored plan program, and those will be distributed to each of the plans on a monthly basis. So that's all part of it. I actually had this slide again. I don't know why I had to do it twice, but it was that good. And so, again, I think that to many people's point, this took time to get here. It was deliberate. And it's because of the populations that we serve that we needed to make sure that the health plans are ready. And we have put together a very rigorous testing plan for them, and they passed. So we feel confident that they will be able to go live on July 1st. Of course, there will be bumps, and we are preparing for those. And we have a help center that people can escalate issues to. We have a member ombudsman that is independent of the department, independent of the health plans, that is here also to serve people. So we are prepared to serve the individuals within this program. All right, I have two more presentations that I'm supposed to get through in the next 12 minutes. All right, I can, but poor Luke has to load them. All right, you should just get the other one ready.
Senator Heiss, your microphone's still on. Did you have another question? Thank you, sir.
All right. NC Health Works, again, we call this Medicaid expansion in the department. We are at, and I apologize, I think we are at 416,536 people today who have been enrolled in Medicaid expansion. Like we talked about a little earlier today, we have seen a light decline in the number of applications, and so this is not unexpected. We were on a very fierce and ferocious pace. We are now leaning on community outreach, and we'll talk about the Medicaid Ambassador Program very briefly in a minute. We're also doing media campaigns and back to school campaigns, and this is now going to be the work to get more people interested in applying for Medicaid. We have a number of individuals who have applied in the past, got rejected or declined, and now are nervous. Nobody wants to be rejected or declined. And so we're trying to get them back to reapply for Medicaid expansion because they may be eligible now. This was a slide that Adam was supposed to present. We moved it over here just because it flowed a little better. But this is, where is the money that we, as part of expansion, NC Health Works, where is it going? And right now, we do not have the detailed information. We will start to get that claim detail from the Medicaid managed care companies. But at a top line level, you can see that most of the money for the expansion population is going to the Medicaid managed care companies. This is not unsurprising. These are people, if they were eligible for the waivers, they were likely in the waivers. So these are individuals who are most like traditional Medicaid, and therefore they're going to the Medicaid managed care organizations. This is comparing to traditional Medicaid expenditure, which is a little different because the program's a little bigger in traditional Medicaid. I think what we will start to see is, as we get into the actual detail of the services that are being provided, I think that's going to be the real interesting, the detail that will be interesting. It's difficult not to talk about expansion without talking about enrollment. We've already talked about enrollment a lot. One item that I do want to highlight for individuals is that as part of Medicaid expansion, we did become a federally facilitated marketplace determination state. It's called FFMD. And so we are an FFMD state starting on February 1st. This is a great relief for our counties. I've seen some of our reports that have come in on, there are certain days where a third of the application volume is going through the FFMD. This is a third of the application volume that is not going through our county offices. And that again lets them focus on adult redeterminations and serving the members that come in for all the work that our county partners are supporting. We continue to work very hard with them to do automation and understand what technical assistance they need. And so that's a big focus of ours. I won't have enough time to talk in depth about one of these innovative programs that we've brought to North Carolina to support Medicaid expansion and the application process. There is more detail at the end of this slide deck that connects people to what is called the communication toolkit. This is a toolkit that anybody can go and download. It has the resources and tools that you need in order to support somebody who's interested in learning more about expansion or getting enrolled. But the Medicaid Ambassador Program is a way of using volunteers who are excited about helping people within their communities to get involved and get them enrolled in Medicaid expansion. And so we've been working with some libraries that have approached us, some children's health centers. Again, the big piece here is just how we are going to need to do things differently with the expansion population as we move forward. We're going to need community partners all across North Carolina to help us find those individuals who should be applying for Medicaid and Medicaid expansion. This was same slide we've had in the last three about our provider enrollment. I've also been asked to speak again about our temporary savings fund transfers. Because of the timing of today's presentation, we don't have a updated detail. We can provide that probably in a week or so. We have 2 months of data. I believe that let me go back one. I believe we have collected 140, I'm being signaled to 140 million receipts for January and February. We're waiting for the March final data to come in. Apologies to the committee for that. This is detail, and given the time frame, I'm not going to read this line by line. And here are the important toolkits that folks can use. There's really good resource dashboards that we have created so that you can monitor our progress and how things are going in our work. All right.
All right, explain everything about PBMs in 2 minutes.
Well, you owe Representative Potts a quarter. So I'll have to say pharmacy benefit manager. To say it in 2 minutes, I think that what's really important is that We have individuals at North Carolina Medicaid that wake up every day thinking about how they can expand access to promising therapies that are going to change lives and keep people healthy, while at the same time managing the best value for the state of North Carolina. We at North Carolina Medicaid, we have a very unique program. We have a pharmacy benefit we control the pharmacy benefit manager and the preferred drug list. And those two components work in concert so that while we are able to purchase $2.8 billion worth of pharmaceuticals for the members of North Carolina Medicaid, it actually only costs, and I say only, but it only costs the state $400 million, or a little over $400 million. That is, I believe, an 86% recovery rate that we're able to defer costs. And where it comes from is you start with federal match. We have this benefit that our commercial pharmacy benefit manager partners don't have. We get federal match. We also, because we control the preferred drug list, we are able to maximize the cost that manufacturers charge the state for access to our preferred drug list. We're also able to take advantage of federally negotiated rebates, and we participate in a consortium of other states that negotiate supplemental rebates. We're also able to negotiate some supplemental rebates under the preferred drug list program as well. So this is the way that we're able to save an incredible amount of money while still providing access to all of these promising therapies. Whoops. Actually, I want to thank Representative Baker for the work that we did last year in making sure that we're looking at therapies in our preferred drug list that may not be traditional. That this is something that allows us to come back to the preferred drug list, to look at other promising therapies, and to contemplate how we can bring them into the program and, again, create that opportunity for promising therapies while maintaining value. My last part, Chairman, is really around the PDL, and I tried to avoid an acronym. The preferred drug list and how it works in North Carolina Medicaid. It allows us to maximize those drug rebates. It allows us to also, because we establish the preferred drug list, we require the preferred drug list to be used by all the managed care companies. That means that every North Carolina Medicaid beneficiary, whether they're in fee-for-service or in Medicaid managed care, or at any of the potentially 10 health plans in Medicaid managed care, they all have access to the same drugs. They can all expect the same kind of access that anybody else would get. This helps our pharmacists too. We've talked a lot about the administrative burden. They're only dealing with our program effectively here at North Carolina Medicaid. One last piece is we use a tool that many commercial pharmacy benefit managers or other programs may not use as much as we do, and that is around utilization management. We establish clinical criteria that we incorporate in our program that the health plans can be no more restrictive than our program. Again, this creates a consistent experience for our members, our providers, and our pharmacies across North Carolina. So the bottom line, sir, is that we have a team at North Carolina Medicaid that works every day to increase access to these new, innovative, promising therapies while working very hard to be good stewards of those precious taxpayer dollars. And I'm not going to go into all of the other details, though you can read them at home.
Senator Adcock gets one question. One comment.
Thank you, Mr. Chairman. Another advantage of having a single preferred drug list is that your care and the medications you can take for it is not dependent on your geography.
Yes.
So when you move from one LME MCO to another, you could suddenly not have access to the very drug you need for your depression or your diabetes or whatever. So gung-ho.
I want to thank everybody for being here. I'm sorry about, if anyone has any questions, if you'll submit them to the chairs, we'll get the answers and send them to everybody on the committee. I'm big about everybody needs to get all the same information. So if you will do that, members, if you did not turn in one of these, you need to fill it out. Even if you were in the morning session, you need to fill it out and turn in the afternoon one. I want to thank all of our folks at the LME MCOs, everyone else for staying and being here. We are adjourned. Thank you.